Hello and welcome to the Talk to Defeat ALS podcast. I'm your host, Tony Heil, Director of Communications and Public Policy here at the ALS Association, Greater Philadelphia chapter. And we're here today with a couple very special podcast episodes. We have had many different podcasts discussing research, care services, advocacy, and all other parts of our mission. Those are the core parts, of course. And we just had a very major conference in Texas to talk about clinical care and topics that I'm not an expert in, but thankfully we have guests who are, and we're going to be talking in a two-part series here on our podcast about what happened at the ALS Clinical Conference and what that is, and some of the lessons learned from that moving forward to help with ALS care and research, right? Mm-hmm. So this one, part one, we have our Director of Care Services, Steve Spaulding. Steve, say hi.
Hello, folks.
All right, I was waiting for you to say hi. No one can see you. Like, nodding doesn't work on a podcast. And we have Alisa Brownlee, Director of our Assistive Technology Program. And Alisa, I know you just said hi, but I interrupted you.
Hi.
And Gail Houseman, nurse at our chapter, who's been with us for almost as long as Alisa, but both of them quite a while. So Gail, say hi.
Hi.
And so, Alisa, I'm glad we're starting part one with you three, because you can explain what is the clinical conference.
Sure.
You've been there before?
Yes. So we started the National Association started a clinical conference, I want to say 15, 18 years ago. And it was just a small group of individuals, and it was in conjunction with Advocacy Day. So I want to say about 10 years ago, the national office realized the importance of having a conference totally dedicated to clinical professionals, and we've done that every 2 years since. Every year it's grown and grown. We have representation from almost all over the country, and this year actually we had folks from the ALS Society of Canada come down. So again, we do this every 2 years. And we rotate where convenient city. This year it happened to be Dallas, which was, Fort Worth, which was an easy fly-in from all over the country. We had 507 attendees, and almost 400 of them were medical professionals that were there for continuing education credits.
And that's great. You've been there before. Can you put that in context? Is that a big spike?
Huge spike. I think the largest number we ever had before was about 320.
Oh, wow. That is big.
And so that was in Arizona. So this one was, 25% more, if not. I don't know my math fairly well, but it was huge. A big difference from 2016. And
do you think is that because there's anything bigger going on? Is there more interest, or like the amount of people providing care is growing?
Well, the disease itself doesn't change, but the way we treat it certainly does.
Right.
And there are new drugs to talk about that Gail's going to be talking about, but there's a lot of more interest in palliative care for our folks with ALS, which was really driven home at this conference. I believe there were 5 different top oral presentations on palliative care.
And before, I know that we've discussed before. Explain palliative care in a sentence.
Symptom management, really, for the person with ALS, yeah.
Which is a lot of part what we do.
Right.
Not me necessarily, but the ALS Association does.
Right, and one of the things that was also a priority at the conference was talking about our veterans with ALS. As almost everyone knows, our veterans have a 60% higher incidence rate than the general public. And we had a tremendous amount of people at the conference who not only worked for the Veterans Administration, but also spoke on behalf of the VA, of their programs, of their palliative care program, of what other veterans were addressed. Do you guys remember? We had one of the doctors from the VA talked about adaptive sports. That's never been mentioned at an ALS conference before. So it was a real asset to have the VA so well represented. And from an attendee standpoint, it's good that I know what the VA pays for, what they don't, and how to maneuver through the VA system, which is very different than maneuvering through the insurance system.
And I've been here a lot less than you. I've been here for 7 years. You've been here for 20 plus. And you've been here before it was considered a service-connected disease.
Mm-hmm.
So it's been a very big positive change in terms of the relationship with the VA.
Absolutely.
That's a really big positive step that I don't think a lot of people will appreciate, because why would they if they didn't know that history?
And some VAs are actually having an ALS clinic. Do you want to talk a little bit about our ALS clinic in Philadelphia, Dr. Quinn?
Yeah, so Dr. Quinn runs the Philadelphia VA ALS clinic, and they do a really nice job there. Basically, that captures not only the immediate Philadelphia area, but folks come in from other parts of the whole eastern half of Pennsylvania to the VA in Philadelphia. And he has been collaborating with us and has been coordinating with us to really provide an extender into the community with all of our care services, as well as supporting the work that he and his team do there. The VA clinic is relatively new. I guess it's a couple of years. And so it's grown over, and certainly grown recently. And we're happy to be partnering with Dr. Quinn and his team in helping to continue to develop that effort to meet the needs of veterans in our immediate area throughout, as well as throughout our entire chapter footprint. We also work at our Hershey Clinic with the VA in central Pennsylvania and have an excellent relationship with them as well, also to serve our population in the western part of our chapter.
And one of the things I just want to mention, since we're talking about the VA clinic, is that it emulates a regular ALS multidisciplinary clinic. I think sometimes people think, oh, it's a VA clinic, I'm just seeing the VA doctor, and that's not true.
That's correct. Yeah, it is a multidisciplinary treatment team, just like our other clinics. So you're seeing PT, OT, speech therapy, our social workers, nurses, and then all the sort of support services. So assessment for measurement for power wheelchair, and then of course we support them in the community in terms of extending for equipment and needs, and all of that loops together in one process, as it does with all of our clinics.
And I think that was why it's so vital to have the VA be part of this clinic, this conference, because they are more and more clinics are now working in conjunction with the ALS Association VA clinic. So it's really important that we move together almost as a unit to provide better care to people with ALS, veterans and non-veterans.
And the non-veterans too, because I know that a lot of those veterans that go to the VA clinics end up helping us in various ways. Mm-hmm. They're a very giving group. There's one who told me, what can I do to help more? Just this week for Thanksgiving, they wanted to help someone in need. Well, that's amazing. But also, because the VA, as you said you were learning at the conference, does so many things, we learn other things that we could do better.
And I think that's the beauty of the clinical conference, I think, is that we all walked away with something that we were really jazzed about. And I think you said it right, Gail. She said she felt recharged because there's a lot of drain in the work that we do.
Understandably, yeah.
And I loved your terminology of being recharged. But I walked away with so many different ideas for assistive technology. I mean, I did 2 presentations, one on home modifications and one on voice banking, but I learned mostly from my colleagues, and I go, you're doing that? I'm going to emulate that. So that's what I walked away from, is that I got some great ideas from my other fellow assistive technology colleagues.
Yeah, and I think to follow up on Alisa's point, one of the wonderful things about this clinic, this clinical conference, was that our chapter had the opportunity to share some of our best practices, our good ideas, the things we've learned, as well as take away some great ideas and things from other chapters that they've developed around the country. So we got an opportunity to, in addition to the excellent presentations that Alisa contributed, we got to talk about some of the early data on Radicava, which Gail will talk about in a little bit, and we got an opportunity to share a little bit about the social work perspective on caring for the caregiver and helping them to care for those that they're caring for. And then talk about some very prevalent issues around the Medicare home care benefit and many other topics that we contributed to, and then, of course, things we took back with us in terms of great ideas and concepts from around the country that we hope to implement here.
And because we had so many people contributing, I imagine that in addition to learning directly from listening to others, just taking the time to put together those presentations, you end up learning more about, because you don't have time to step back. So Gail, you're nodding, and I'm sorry that you were typing before. So What did you take into account from putting together your presentation? What was your presentation?
So Judy Guarnieri and I. Judy is a nurse practitioner at the Jefferson Weinberg ALS Center. So Judy and I looked at our patients who were on Radicava over the last 12 months, and we presented on that. We basically presented on the data that we got from either objective data or subjective data. So just to start about Radicava, the drug was approved in Japan and South Korea to treat ALS. It was based on a study that MT Pharma did that looked at people with ALS who had to meet certain inclusion criteria. They were mostly higher functioning people in the sense that their functional rating scale had to be one of the higher scales. There's a bunch of different categories, and the categories are from 0 to 4, and people had to score at least a 2 in each category. So the participants of this study were all people that were higher functioning, had a higher forced vital capacity, which is when you blow into the tube. They all had to have 2 years or less onset of symptoms, and they had to have a clinical definite or probable ALS. They also had to be people with ALS who showed some decrease over time in their functional rating scale, because there are people with ALS who show little to no decrease in their functional rating scale over a period of time. And so the Japanese study, they wanted to make sure that these were people that were going to progress over time.
So that means they were progressing before they got on Radicava.
Yes, there was what they call an observation period to make sure that all of these participants were people that were progressing over time.
And part of the reason you're able to do this reporting is because you've been working there on this for so many years. Judy has too, so you know the kind of data to be getting for years before this. So you're not going in blind to any of this information.
Right. So then we, the Japanese study, what came out of that was that there was a statistical significance between the patients getting the Radicava versus the patients getting the placebo. And just as an FYI, in Japan, the drug is called Andarabone, but it's the same as we call it Radicava here. So there was a statistical significance about a third. There was a third less progression in the Radicava group. So based on that information, our FDA approved the drug in May of 2017. First drug in 22 years that's been out for treatment of ALS. And our first patient at the Jefferson Clinic was given Radicava in September of 17. So we looked at 23 patients over a period of 12 months to see about objective data and subjective reports, and basically we just presented on our data. We also presented on some of the problems that we've run into, getting it covered by insurance, getting people to get to a center to get the Radicava, because it's given via an IV, a port, usually in the chest, and we had to, for some of these patients, based on their insurance, they had to go to a place to get the drug. The fact that it's given 10 days, you're on the drug, then you're off for 14 days, then you go back for 10 days, then you go off for 14 days, and it's back and forth. So basically every 2 weeks they have to go and get the drug. It's not covered by all insurances. So there's issues getting the port set up. We wondered about quality of life. Like, is this something that we want to recommend based on quality of life? because of the going back and forth to get the drug. We also were concerned about people that were at the point of needing either palliative care or hospice, if this would delay them getting on the palliative care or hospice program. So we had 23 patients that we looked at, and basically we looked at their functional rating scale. So after 6 months, the drop was about 4.9 or so, and after 9 months, the drop was about 6.3. And that's a little less than what's considered average as far as the functional rating scale. The average is about 1.1 decrease in the functional rating scale per month.
But now you might have more things to look at because you've done a lot of this data crunching.
Right. So the other thing that we found is people that had sort of the atypical form of ALS, meaning that they were either upper motor neuron or lower motor neuron predominant, had practically no progression, although we would expect them to have very, very, very little progression over time. And then there were, adverse effects, subjective complaints. There were objective complaints like fever, weight loss, infected ports. Subjectively, some of the folks felt like they were not sure if it helped. Some folks felt like it didn't help. The majority felt as if the drug did help them in various ways. So then Judy and I mentioned or talked about the functional rating scale, which is the tool that they used in the Japanese study to measure functional decline in ALS. And there's some literature out there suggesting that the functional rating scale is not the best scale to use independently to look at functional decline. But so we just talked about that a little bit. We also talked about barriers to receiving Radicava in that it's not covered by all health insurance. So we have some people that are just not able to get on the drug because it's about $148,000 a year for this medication, and most people don't have the funds for that. Medicare, if you're on Medicare, it will only cover you if you go to a center. So we have 2 patients that were not able to get on Radicava because they had nobody to take them to the places to get it. The cost of the drug. We talked about patient and caregiver expectations about Radicava. We felt like we needed to explain that this isn't a cure. It's supposed to slow progression. We talked about hospice versus going on Radicava, that hospice is not going to pay for Radicava, and that the Japanese study was limited as far as length of time that they studied this. So they looked at patients on drug, and then they looked at people getting placebos, or patients getting placebos over a 6-month period. So we were wondering what happens like after the 6 months. I mean, is the drug still going to be effective? And then we talked about that there's no conclusive evidence that on the effectiveness of Radicava for ALS people who do not meet the Japanese criteria. So for our people that had lower functional rating scores and lower forced vital capacities and maybe had ALS for a while, there's no data that suggests that Radicava would be helpful for them. It might be, but there's no data. We also wondered how helpful it will be over time.
So there'll be more information that you'll need to get and will get in the future.
Well, we're hoping for ongoing research to look at Radicava for patients or for people with ALS who don't necessarily meet the Japanese criteria, and we're also looking for research that focuses on measuring what Radicava is supposed to do. Radicava is supposed to sort of fight the oxidants in our system, and so we're hoping to see research that suggests that the Radicava is doing what it's supposed to be doing.
So, but from your years of experience, it'll take time to get all this information. There'll be new data over the years. And hopefully that information, the studies, will improve what the recommendations are, the treatment levels,
Right.
Make it easier, hopefully, to get the drug, access to it.
Yeah.
So the information that you put together and presented, that kind of information going forward will hopefully lead to better treatments with this drug and with future drugs as well.
Yes.
That's the goal.
Was there any discussion at the conference about the clinical trial of the drug Radicava in the pill form?
No, I mean, I did hear about that, but we didn't bring that up.
Not you, but was there anything at the conference?
Nobody happened to talk about that.
So there's a lot that we'll be discussing.
Yeah.
Right, that's in the future.
Yeah.
And so it's exciting that there's a new treatment. It's the first treatment since you've been here.
Yeah.
But with any new treatment, there's going to be fits and starts moving out, and there's going to be a lot of hopefully potential positive growth. But you have to keep waiting for that information, and it's not always easy to be patient for people with ALS or for any of us that care for them.
That's right. Yeah.
That's good. So are you glad you did it? Are you glad?
I'm glad it's over.
Okay. You seem a little bit stressed going into it, right?
Yeah.
That was a lot to do, but it was well received, right?
Yeah.
Absolutely.
Yeah.
I think you had one of the busiest.
Yeah, 507 people there. There were probably 503 that were watching, right? Couple people to sit back.
Well, I have to say, I spoke at the same time she did, and my room was half empty, and her room was overflowing. But that's okay. That's what we had 3 tracks at once.
Mm-hmm.
So I just happened to draw the unlucky straw of going against you. But this is the information that people wanted, and I think it proves why this conference is so important. That they wanted to hear your information.
That's good, and also that they trust where you're coming from. It's not like you're Gail Houseman, person on the street. Right. You and Judy you come forth with your own credentials that people can say, they're people we should listen to. Right? The clinical conference is full of people like yourselves who people want to hear what you have to say. If I went to present and said something, not that I'm not a smart person, but people are going to care more about what you, as a nurse with many years of experience, and Judy from her work, they're going to care about what you have to say because you're going to know it better.
All right.
I think so. I would listen to you. I ask you all sorts of questions. So you didn't have as many people at the same time.
No.
But people could still find your conference, right,
yes.
Alisa?
And I will
and tell us what you talked about, because we didn't get to you yet.
Sure. I talked about, I did 2 sessions on home modifications, and then I did a session on voice banking. I should point out that the national office is going to have all of these presentations housed in a website so that the general public can click on and get Gail's slides, and anybody else that you want to see, you can see their PowerPoint or their PDF. Mm-hmm. So that you don't have to attend the conference necessarily to see the content, and that should be up. I don't have an exact date. We just sent everything to the national office last week, but I'm going to anticipate by early December it'll be up on a website.
And the people that attended will be able to get in touch with the presenters like yourself and Gail?
Yep, the presenters' emails and phone numbers will be there.
And that's one of the best parts of this conference is that interaction with people across the country.
Absolutely. So we had 27 different posters, and all the posters will also be in that website. The posters are going to be in PDF format, so they basically look like a picture, and you can read the poster content. Most of them are talking about a study, but some of the posters are not. Some of them are about programs, so you can absolutely click on them too to look at the posters. Great.
So what did you most get out of presenting about? Like what because have you presented there before?
Uh-huh.
And so can you give us a little bit more detail about like the main things that you were able to discuss and learn even as you were putting it together?
Well, there's 2 things. The voice banking is changing. The landscape of this is changing.
How long has voice banking been going on?
Many years,
right.
Like 20 years. Model Talker started, but now all these other companies are starting. There's a company called Acapello, and then there's a project through the national office called Project Revoice. Mm-hmm. And so the options are getting better for our folks. In the old days, it would take like 20 hours to make your voice. Now, Acapello and Project Revoice are saying maybe 3 to 4 hours. Well, that's a huge difference for the person with ALS. It's a huge fatigue issue. They get tired. And so if we can eliminate the needless time of voice banking. So that was one thing I was so glad to hear about these companies. And then the second was really interesting about home modifications, because home modifications, and when I do home visits about them, are just not about the home. It turns into a whole issue about home care and being left alone and wanting to stay in your place that is personal and that you have a connection to. And that's what the most times people feel about their homes. And they also don't want to make changes. And I came from my grandmother, who had a leopard skin sofa with the clear, the clear plastic around it, so you would sit down in the summer and your thighs would stick as you got up from the shirt. Yeah, my grandmother would be the perfect person to say that woman would have never moved an inch off of that coffee table to make room for a wheelchair or anything else. So talking about home visits for home modifications, or even any kind of adaptations of their home environment, is such a psychosocial issue. And I really felt that we had a really great dialogue and sharing from not only the attendees that came to my session, but also a smaller session that we did. Like there's just so much more involved in it. And so it was good to hear that, because I tell Steve that all the time, and I say to Gail, I'm doing this home visit, but we didn't talk about home modification, because it tends to bring out everything else that's going on in the house.
Mm-hmm.
So, but that's what I walked away with.
And that's something that I know you've been working on for so many years, so there's always ways to improve those conversations.
Absolutely.
And that in turn improves quality of life. Yep. And that's our main job here, is improving quality of life.
And Steve would talk about quality of life for kids, right?
Oh, yeah.
I didn't even realize the quality of life for kids. That's something we don't talk about enough. It's because it's a hard thing to talk about, just as human beings.
Yeah, I had an opportunity one of the things I attended is called Y Care, and it's a program that Dr. Melinda Cavanaugh started at the University of Wisconsin. And she presented, I had an opportunity to speak with her a little bit. Basically, the program provides what I would call a workshop, so that the kids come in, and it's typically a group of kids who have been pre-invited to come in, and they move from sort of area to area. And it covers everything from training to emotional support to dealing with tough issues that come up with either a family member who has ALS currently, or unfortunately who was recently lost to ALS. And then there's the pre and post. So the program supports the kids, really before they even go into this workshop, and then post that workshop in terms of what they do to support them. So it's a great model, and something definitely one of those takeaways we talked about earlier in this conversation in terms of what we might look at to do here in our chapter. That was really interesting. And then the other piece that I had an opportunity to be part of a conversation was the Medicare home care benefit.
Yeah, you were talking about that earlier today.
Yeah.
It's a very complicated subject.
It is a very complicated subject, and I think some of the basics of it that everybody can relate to and connect to is the frustration with what officially is sort of the word from CMS, which is Medicare, that, hey, you have access to a home care benefit, and the reality that finding a provider and having the ability to access that benefit is either very difficult or impossible in many cases to actually utilize. There's a lot of reasons for that, but one of the takeaways in terms of the solution is our chapter, in cooperation with the National ALS Association, is looking at the possibility of implementing a demonstration project, which would allow us to show CMS, Medicare, that there's a way to help fund in-home care for folks with ALS, and specifically, most importantly, for folks who are vented and need nursing level or LPN level care for in-home care. They're looking at potentially one of the options is called PACE, which is a program that's been in existence for about 15 years. That was originally designed for elderly folks, but it's basically wraparound care that's designed around a specific hub of treatment. And we in the Pennsylvania area call this LIFE programs, which a lot of your listeners will be familiar with, the LIFE programs throughout the southeastern Pennsylvania, as well as actually throughout the state of Pennsylvania. So something along those lines is being explored now as one way of addressing this issue and perhaps finally breaking through some of the barriers to actually achieve a real benefit for people with ALS in the in-home care side.
And so attending this conference, just like Gail's information on Radicava, is not so much going to get the answer, but to better understand the problem so that we can be better advocates, both in terms of lobbying legislators and also advocates for the people we care for and that personal advocacy, so that we might be able to get better answers to improve the whole healthcare system, not just for people with ALS, potentially.
Absolutely. The applications of this are not only for our mission, but extend to the mission of many other individuals and organizations. Yeah.
Great. So the ALS Association can lead the way, and as Alisa remembers, it used to be one of our mottos, I think. So that's a benefit to this conference, is that we're learning a lot about the problems that exist in better ways. So you're better educating, you're better presenting, and learning through that education, that you're learning through putting together your own presentations. I mean, this is why you're better presenters than I am, because I can't see presentation. And that in turn we can kind of figure out what to do internally, right? As a care team, you can figure that out and provide better care and search for better answers.
And I would conclude by saying that getting us all together, healthcare professionals, and I mentioned this earlier with Gail's terminology of being replugged, but what we do is extremely tough. It is emotionally tough. We get involved with our families. We walk this journey with them. And at the conference, a lot of, besides, being recharged, we talked about resiliency, we talked about mindfulness, and we talked about taking care of yourself as a healthcare professional. And we hear that a lot, but, you kind of, oh, yeah. And if you're in that session, that teacher, that educator is making you be mindful at that time, so she or he is kind of, I'm not saying forcing, but they're basically involving you in the exercise. And so it's so important that we take care of ourselves. And I saw that throughout the whole conference of people going, okay, okay, they're right, and validating sometimes the compassion fatigue that we have.
Yeah, and I see that all over the place when I go to meet with people. And I only see that on a separate level than what you do, because you're seeing the people with ALS daily, weekly, all the time at clinics and at home visits, and I don't see it at the same level, but even from my distance, I can see how much that is an issue with personal caregivers, and I know that everyone here has met hundreds or thousands of people with ALS over their years at the ALS Association, and it becomes very hard. Sometimes it feels hard to get criticism, too, because you're like, this is personal to me.
Right.
It's not just going into work and tuning it off at 5 o'clock or
right.
whatever time you leave.
Yeah.
So, well, thanks. I'm glad you guys got a lot out of it.
Thank you.
And we're going to get ready for part 2 with our social work team that went there, because it's a whole team experience, right, Steve?
Absolutely.
We don't just have one type of caregiver. It's the clinics are a whole team approach, and that's what we're going to keep going on with part 2 of this clinical conference. To find out more about how you can get involved in the fight against ALS, contribute, volunteer, or learn about research and care services, go to alsphiladelphia.org. Of course, follow us on every social media channel as well at ALS Philadelphia on YouTube, Facebook, Twitter, Instagram, LinkedIn. We had Snapchat for a minute, so maybe that still exists. And we'll also on our Facebook include some of the links to this information so you can learn more. Thanks again, guys.
Thank you.